can hear you very clearly.
Great. Okay, so I shall start. And Saif Bani-Orab is also online. He's the person behind this talk, really. He's my Corneal fellow. He's currently doing a clinic, taking a 10-minute break to be here. Sorry, I jumped the queue because I also have to catch a flight. And in fact, I couldn't be with you today because nobody would drive me to central London because of the train strikes, because they know it would take 3 hours, right? So my brief is to, in the next 2 minutes, talk about diagnostic armamentarium of infectious keratitis. So declarations that Safe has helped me put this talk together, but I have infused the talk with some pearls acquired over 35 years of practice, and all errors and omissions are mine. And you can see that I have had COVID over the Platinum Jubilee weekend. So if there are any problems with the talk, it's all my fault. So just starting with a few pearls, that prevention is better than cure. So be aware of extended wear contact lenses, because we know that nighttime wear increases the risk of infectious keratitis. Swimming and showering whilst wearing contact lenses, that's a risk for acanthamoeba. Indiscriminate use of steroids obviously make more susceptible to infectious keratitis too. Early diagnosis is very important. So if the contact lens wearer has been instructed, if the eye becomes painful and sensitive to light, then they remove the contact lens, bring it in the case, and present immediately. Then we can look at the eye and also culture the case and the contact lens and start treatments immediately. Early treatment is important, and we know in much of Africa, and treatment is also very late because in the depths of the countries, there is actually no availability of antimicrobial compounds, especially antifungals. We need to be aware of co-infection, meaning more than one bug infecting at the same time, and a superinfection when a second bug infects already pre-infected cornea. There are never diagnoses as contact lens abrasion, especially in a soft lens wearer, because soft lenses do not abrade, and usually there could be an early infection. Equally, we've already heard from David Lockington about putting a label of herpes simplex keratitis on patients, and certainly with contact lens wearer with no previous history of herpes simplex keratitis, you should be very suspicious of acanthamoeba instead. Now, next, the importance of clinical response. Firstly, when you're trying to culture, no growth does not equal no infection. Equally, if there's a growth, it doesn't mean that there's the causative agent. And also, as David said just now, response to treatment is not proof of causative agent. And I know somebody who would throw triple therapy at a suspected diagnosis of acanthamoeba, the eye gets better, and then they say, oh, it's proven it is acanthamoeba. It is not, because we don't know what it was. We don't know the natural history of what it was. And also the acanthamoeba treatments, such as Proline and so on, can actually treat other agents as well. So next, antibiotic sensitivity is unreliable, especially for fungal infections. So why is that then for bacteria? It is because intense topical treatment with topical antibiotics reaches very high concentrations in the cornea, and when we're testing whether bugs are sensitive, we're looking at kind of levels. So the size of the problem of infectious keratitis is very, very significant, and it affects millions of people each year. And here I bring to your attention that in the developing world, the rate of this happening is much higher than the developed world, for example, in the USA. Diagnosis, as usual, from medical school, we're taught history, examination, and special investigation. So take a good history, do a good clinical examination, and draw the cornea. And I will show you a very good source of how to draw diagrams. But it does give a significant diagnostic and therapeutic challenge. Let's see what that means. So in the history, obviously you take a full history, but pay particular attention to contact lens wear, and if so, the mode of wear, the material, whether it's disposable, and what solutions they use and how they store and neutralize, etc. Any trauma, even minor trauma, can be important. And ocular surface disease, which we've been talking about all day, obviously the more severe ocular surface diseases really predispose the eye to infectious keratitis. Long-term topical steroid use, for example, in your graft patient, corneal graft patient, so the patient may develop all sorts of keratitis, including infectious crystalline infection, and of course, then if you have a broken suture, then can also predispose the corneal graft and the host cornea to infection. Travel history, there are some bugs which are in different parts of the world and different hobbies, including contact with mud, your rugby players, etc. So here is how to draw a good diagram. If you go back all the way back to 1973, it's a long, long time ago. And here's a full PDF. And Tony Braun, who's now retired, a giant in British corneal practice, will show you how to draw diagrams. Now, this is particularly difficult with EPRs or electronic healthcare records, but on paper you can, if you want to, draw this very nicely, and it is actually even better than a photograph when documenting and in comparing day-to-day progress of a corneal condition. So I think we've already beaten this to death, that the dendritic stain, dendritic pattern stain, does not equal hepatic. There are many, many causes, including early acanthamoeba and a healing corneal abrasion. Now, if you can see any radiokeratoneuritis, then you know that it's diagnostic of acanthamoeba. And if you see feathery borders and satellite lesions, they are suggestive of fungal keratitis. However, these are only suggestions. Clinical appearance can only give a hint of causative organism, and most clinical features are unreliable. And there may be more than one causative agent. And then we have also the problem when you try and culture, the positivity rate is low. And there's a long turnaround time for diagnostic testing, but it still should be done, because if it doesn't respond, then you have something to go back on. If it responds, then so much the better. So what diagnostic modalities do we have? Basically, we have microbiology, we have imaging, and we have molecular diagnostics. Here, this we have everywhere, but even so, some labs will be much better than others than giving you a positive culture. Imaging not available everywhere, and principally we're talking about in vivo confocal imaging. Molecular diagnostics not very available. There are limitations as well, which we'll go into. So, is your method of getting corneal tissue for plating or putting somewhere else for growth. So culture of corneal scrapes remains the gold standard, and it can determine antimicrobial susceptibility and resistance and guide your choice in non-responsive cases. In responsive cases, it doesn't really matter very much. You just carry on and then the health gets better. So in which cases do we do corneal scrapes? Certainly, I would say, in any sizable ulcer in the contact lens wearer, you should, because that can guide you later on. A central large corneal ulcer with or without stromal involvement, corneal infection or refractory cases, the previous history of corneal surgery, atypical clinical features, multifocal corneal infiltrates, that means many, many bits of infiltrates. So ideally, this should be done before starting antimicrobial treatment, obviously, because then the yield will be much better. However, if you need to rescrape, or you've already the treatment is already started, the patient comes to you for a second opinion, and you take over the care, and the patient is not getting better, and they are using their drops, then you have to stop, to leave the bugs to become a little bit more active and lively, and then rescrape after 1 or 2 days. So usually this is done at the slit lamp under topical anesthesia, and the best one to use is proximeticaine, because it has less antibacterial effect than the other commonly used topical anesthesia. Now there are different methods, but I use a green needle for every single scrape, and then I plate. Now obviously you have to remove loose mucus and debris, because there's no point getting this, there'll be not going to be any live bugs there. You need to just wipe that off first, and then scrape and wear the there's active infection, so in the edges of the ulcer, in the base probably less so. So this is the kind of sensitivity you get from gram staining HEMSA and potassium hydroxide. This staining is not very much used nowadays, but it does give instant results. So as I said, this is gold standard, and it helps to determine the susceptibility and resistance profile and guide and modify antimicrobial treatment. Cases, infectious keratitis, particularly severe cases, not responsive to the standard therapy. Positivity rate is reported to be ranging from 24 to 77%, and you can either plate directly on solid agar such as blood agar, chocolate agar, sabriotes, or if there is not enough material, you can put it in culture medium and then let the lab deal with it. And then, of course, they might be using broths and methods. And in general, the results of direct plating is comparable to indirect plating. And we've already talked about this. Now, there is a special one, which is non-nutrient agar, which is coated with E. coli, it's sprayed with E. coli, and then you put your scrape there if you are suspicious of acanthamoeba keratitis. However, most labs will actually give you the non-nutrient agar without the E. coli. You plate it, and then they spray E. coli, from you introducing E. coli onto the host cornea. So what is the significant microbial growth then? If the organism grows on two different media, if it's confluence, greater than 10 colonies, and the culture result is consistent with the staining report, and the same organism is grown on repeat scrapes, and so on, then you know that it is for real, and if clinically indicated, you will also culture the contact lens solution and lose corneal suture. Sensitivity, so you have looking at antibiotic and sensitivity. We've already talked about this, that even though the report comes back as resistant and the patient is responding, you know that the very high concentrations from the frequent topical medication is working, and you can continue with that unless there is another antibiotic which says is highly susceptible. Then you may add that and just taper off the other one, which is being used very, very high frequency. Well, you will need to do this when you need to get a chunk of tissue, and for corneal biopsy, usually it's anterior biopsy, and I would do this on a very rare occasion in the operating theatre, although some people will do it at the slit lamp. So basically, you do a small trephine of tissue from the central cornea and send that to a laboratory, and you could divide that, one for histology and the other for microbiology. Now, occasionally, the front of the cornea is actually quiet, and you've got infection going on further back, and you can create a flap and then obtain a posterior corneal biopsy as well. That is also possible. Okay, so it basically tells you how to do it, and I think I've gone through that already. Now, one special case is corneal epithelial sheet biopsy, and you do that. You can do that at slit lamp or on the operating theatre. When you're suspicious of acanthamoeba, you take a whole sheet of epithelium off, while protecting the limbus, of course. You leave that behind, and you divide the sheet of epithelium into two, one half for histology and the other half microbiology. And so here you see a typical double ward acanthamoeba cyst from staining. Now, there's mass spectrometry as one example of imaging. I won't go into this. Cytology, which is you anesthetize the eye and you use a filter paper and you put that onto the anesthetized cornea and let it kind of dry and stick on, and then you pull on that whole sheet of cells, and then you can stain that to look. Okay, so it's not practiced very much, but it can be done. So let's quickly look at in vivo confocal microscopy, which is not available everywhere. But from where I work in Brighton, if I need this service, then I send the patient up to Moorfields for them to have a look-see. So this enables non-invasive, high-resolution in vivo evaluation of corneal structures and pathology at and you can look for fungal hyphae and yeast, and also acanthamoeba keratitis, both trophocytes and also the cysts. So the overall sensitivity and specificity of in vivo confocal in detecting fungal pathogens, particularly filaments, is estimated to be 2/3 to 85%, and 81. So filaments appear as high contrast, hyperreflective lines resembling hyphae with 45 or 90-degree branching patterns on the confocal, whereas Candida species, yeast-like fungi, appear as elongated, hyperreflective particles resembling pseudofilaments. Acanthamoeba species may present in various morphological appearances. So you have your cysts, you can have worms, trophozoites, bright spots, signet rings, and perineural infiltrates, which is pathognomic. So let's have a look at a couple of images. So you've got these cysts and bright spots of acanthamoeba. You've got these hyphae from filamentous fungi. Then we'll move on to molecular diagnostics, which is basically PCR, and it is a very significant breakthrough in biomedical science. And it is rapid and highly enzymatic assay. It enables amplification of the targeted DNA fragments within the DNA sample. It's highly sensitive. Many would say too sensitive, with only a small amount of DNA required to yield a positive result. So explored and utilized in profiling antimicrobial susceptibility and resistance, and PCR has increasingly been used to improve the diagnosis of a wide range of infectious diseases due to its rapid time, about 3 hours, and versatility. Okay, so it's also been used in diagnosing and distinguishing between different types of viral keratitis. The inherent weaknesses are it over-amplifies a targeted DNA sequence based on a specific primer. So background contamination can amplify normal flora, and microbial DNA can still be detected despite following successful antimicrobial treatments. And its high cost, low availability, and the impossibility to test antibiotic susceptibility makes it less useful. But to sum up, conventional microbiological investigations, microscopy, culture, and sensitivity should be considered and performed in all patients with ulcers greater or equal to 2 millimeters, sight-threatening infection, atypical infection, and lens wearers. You should use a standardized and optimized corneal sampling technique, and where available, combine conventional microbiology and molecular diagnostics should be used. And then you have serial imaging, slit lamp photographs, and anterior segment OCT could provide objective quantification of the baseline severity and progression. But equally, you can be studious and assiduously draw diagrams, and then finally, in vivo confocal serves as a powerful adjuvant tool if acanthamoeba or fungal infection is suspected. Thank you very much.